Tonight, we are thrilled to welcome Dr. Karyll Gonzalez. Dr. Gonzalez is an intensivist at St. Mary's Hospital in Grand Junction, Colorado. But when he's not saving lives in the ICU, you'll likely find him out in the wild. He's an avid camper, hiker, scuba diver, and sailor, and he's most at home when he's either in the backcountry or beneath the waves. He's also a dedicated family man who adores his wife and young daughter. Dr. Gonzalez earned his FOM, Fellowship in the Academy of Wilderness Medicine, and is currently working toward his DiDMM. Did I say that right? The Diploma in Diving and Marine Medicine. Tonight's talk is titled When Oceans Attack, a fascinating dive into marine animal attacks, infections, dermatitis, parasites, and how to treat them. And here's a bonus. Dr. Gonzalez is also an accomplished photographer, so many of the photos and videos you'll see tonight are his very own. As questions come up throughout the chat or throughout the lecture, please feel free to come off mute and ask. You can also type them into the chat and we'll monitor that as we go. Please join me in giving a warm welcome to Dr. Karyll Gonzalez.
All right, everybody, welcome. So as Amy said, my name's Karyll. So I'm an ICU doc, but I also do a lot of diving and a lot of underwater photography. Just to correct Amy's, all the videos, actually none of the videos are mine, but the majority of the photos are mine. Some of the videos I borrowed from Dive Buddies or just YouTube available online, just to emphasize some of our topics. So even though I have no conflict of interest, even though I live in Colorado, I am, or formerly was a dive master. I got certified as a dive master when I was in college. I took a year off between college and med school, and I worked as a dive master in South Florida. I have logged all the places I dove, and yes, I realized that I'm a sailor. And as Amy said, I have my fellowship in the Academy of Wilderness Medicine, and I'm currently a candidate for the Diploma in Dive and Marine Medicine. The outline of our lecture today, I decided to basically go based on the mechanism of injury. So we're going to talk about bites, stings, punctures, and skin irritants. So why is this important? Basically because of this. This is a video that one of my dive buddies, Dan Trito, who may or may not be on the chat right now, took. This is October of 2021 at Tiger Beach in the Bahamas. So you want to keep your eyes on that nice tiger shark. And then that happened. Thankfully, there was no injuries. This was more scared than anything. And hopefully through this lecture, you're going to learn how to, one, avoid that from happening to you, how to become a casualty or statistic. And two, if it happens to your dive buddy or while you're in a dive boat, hopefully how to respond to it. Oh, let's see if I can. So in creatures that bite, basically everything in the ocean has the ability to bite you. So rather than talk about everything, I decided to talk about creatures that when they bite you, they can threaten your life or your limb. And they happen often enough, or at least make news often enough to warrant its discussions. This photo was mine. This was actually in Tiger Beach. No tigers. Those are all reef sharks right there. All right. So let's talk about sharks. There's over 500 species of sharks, but only about 80 species or so have been implicated in human bites. The most dangerous are just basically because of their sheer size. Those are the great whites and the tigers, bull sharks, hammerheads, gray reefs, black tips, spinners, white tips, and blue sharks. They range from relatively small, the dogfish is about 8.3 inches, all the way to gigantic, such as the whale shark. Thankfully, this is a plankton eater, so never gonna bother you. This picture was actually just taken recently. I took this in January. We were in Kaimana in Indonesia, which is basically Indonesia and Papua. Now, sharks are distributed worldwide. Bull sharks can actually be found in fresh water. They have been found in Iquitos, Peru, and that is 4,000 kilometers from the mouth of in the Amazon River in the of the Atlantic. In the U.S., they have been found in the Mississippi as far north as Illinois. The US actually leads the world in shark attacks, and Florida is actually the shark attack capital of the world. I'm actually from South Florida. For Miami, the majority of injuries happen in the mid-Atlantic around Jupiter Beach. Of the identified sharks that can actually cause bite, the most commonly identified offenders are tend to be the black tips and the spinner sharks. There are other countries that also have a high incidence of shark bites. These are Australia and Egypt. In the US, there's about 100 shark attacks or so per year, with less than 10% of them being fatal. So I don't want to scare you. The odds of you being attacked in North America is about 1 in 10 million. The reality is that you have a better chance of dying driving to the ocean or the boat. About 46,000 people die annually on the road. Boats, there's about 500 people that die annually on boats. In water, there's about 4,000 deaths annually, and about 20 deaths annually from lightning strikes. So again, way more likely that you're going to die of something else rather than being bitten and die of a shark attack. One of my favorite statistics is that you are actually more likely to die from a champagne cork in France than you are from a shark attack. There's about 24 deaths from champagne corks in France every year. Shark attacks, bites, when they do happen, they tend to be crescent shape because of the shape of the mouth of the shark, and they lead to heavy, heavy tissue destructions. Tiger sharks, such as this guy, have a tendency to basically bite and roll, causing severe degloving injury. I should have probably warned you that there are going to be some graphic photos in here. This photo is not mine. This was taken from Austere Medicine, the Arbeck's Austere Medicine textbook, but the tiger shark on their prior image, that one is mine. And again, that was taken at Tiger Beach. Most common death is from exsanguination, and about 50% of bites happen in the lower extremities. Sorry, having a little trouble going through. Have to work two different screens. So I want you guys to know how to prevent a shark attack, how to prevent injuries from everything that we're going to talk about. So basically, prevention: avoid areas frequented by fishermen. There tends to be a lot of fish smell in the water. You want to avoid locations and times where sharks are most active. This tends to be, actually, let me go back. This is again at Tiger Beach. This is on Tuesday. So you can actually see the dive master that's feeding the shark is wearing a tutu, and actually every single diver in the water that day was wearing a tutu. This is again on Tiger Beach. So is this rather than being a tiger shark, it's a lemon shark. So again, how do you avoid being a statistic? Avoid areas frequented by fishermen, avoid locations and times when sharks are active. Twilight, both dawn and dusk, tends to be that. If you are spear fishing, make sure you want to keep your fishes to that distance. It's better to lose your fish, lose your meal than lose your leg. You want to avoid entering the water with any open wounds. However, menstrual blood has been shown time and time again not to attract sharks. Surfers, they are a lot higher risk than divers. That basically is because of the silhouette. You can see on that top left picture, you have the silhouette of either a seal or I'm not sure what happened. Can you guys still see the screen?
We're just seeing a black screen.
Yeah, so am I. I'm not sure what happened there. Let's try that again. There we go. So surfers are at greater risk due to the silhouette of a seal or possibly a turtle. Bright reflective swimmer and diving equipment can be a shark attractant. It is usually recommended to have dark colors, whether that's black or blue. Black, unfortunately, has been associated with increasing great white attacks, and that's possibly because they feed on seals, so they are used to that black color. You want to be able to swim, don't swim alone. You don't want to create a lone target. You want multiple eyes for surveillance. And you want somebody to assist you in case of an attack. You want to make sure that you avoid swimming in turbid water. About 64% of known shark attacks happen in poor visibility. Don't splash. Be very deliberate in your movements, whether you are at the surface or under the water, as you don't want to mimic injured prey. Do not corner any sharks, do not attack the sharks. This may actually trigger a defensive bite. Some of our smaller sharks, things like black tips, can actually be a food source for some of the larger sharks, and they're used to being very voracious if they feel threatened. There's at least anecdotal evidence that sharks are attracted to electronic gear. Out in Tiger Beach, there are a lot of stories of big tiger sharks carrying away very expensive underwater cameras. Porpoises, despite the old wives' tails, are not protective. Sharks can be found regularly with dolphins. Out of Australia, they created something called a shark shield. These are electrodes that you can carry underwater, and it tends to produce an electrical field that is thought to cause discomfort to sharks and muscle contractions. Studies do suggest that they tend to keep the sharks back or about 4 or 5 meters or about 15 feet. Unfortunately, with great whites, when it was tested, it only delayed or reduced the number of attacks. So how do you defend yourself? If an attack does look likely, you want to be able to back yourself up and force a frontal attack. That way, can you defend yourself? Blunt force to the snout, the gills, the eyes, the soft areas of the shark, and if possible, don't use your hands. Meaning, if you have a camera in front of you or something else you can use as a weapon, do that. Things like bang sticks, spears, knives, they can kill a small shark. However, with larger sharks, it may worsen the situation as you may now trigger a defensive attack or a feeding frenzy if multiple sharks are involved. Now, according to the South African Natal Shark Board, most deaths occur secondary to insanguination, usually from a limb injury. So in water, you want to make sure that you compress the wound, and out of the water, use a tourniquet. I'm not sure that many of us carry a tourniquet in water. You want to make sure that you stop massive hemorrhage rapidly, as the victim can lose a lot of blood in a matter of minutes if they have any major arterial or venous bleeding. And remember, blood cannot be replaced in the wilderness. Injuries to the extremity, again, tourniquet placement high and tight, particularly if you have not been able to identify where the source of it. Some injuries are not amendable to tourniquet placement, such as those in the head, neck, and the torso. So you want to make sure that you compress the wound. Usually 5 minutes is what's recommended under the March algorithm. And if there is ongoing bleeding, a repeat with 10 minutes or the feeding artery, whether that is the brachial or femoral artery. Remember, very important, that just because you deployed a tourniquet, it does not mean that the tourniquet has to stay in place once the patient is stabilized, particularly if you're in the middle of nowhere, definitive care is very far away. It is okay to take down that tourniquet as long as you have had control of bleeding. Of course, this happened in water, and with significant blood loss, you can lose consciousness. So you want to make sure that you maintain a pain and airway on any unconscious patients. And of course, because it happened in water, drowning is a real risk. So you want to make sure that you augment the patient's respiration. There's unfortunately nothing much that we could do in the wilderness for circulation, but obviously elevation of the extremities to get more blood flow in the core is recommended. Remember that hypothermia can actually can worsen your bleeding, leading to that death triangle of hypothermia, bleeding, coagulopathy, and acidosis. So all these patients, you want to make sure that you get them dry and get them warm as soon as you possibly can. So what happens after we've now established seeing first aid? You get them to the hospital. So in hospital, you want to make sure that you have prophylactic antibiotic, vaccinations. Again, tetanus, and that patient that's not vaccinated, you want to use tetanus IVIG. Surgical exploration of the wound, as there could be, again, severe tissue damage. You want loose sutures, and you want imaging for any retained teeth. This picture was actually all on the same trip. This is actually I love this picture only because it was the only picture that I could get multiple tiger sharks all at the same time. So now that we've talked about potentially how do you avoid a shark attack, I wanted to show you guys the video again. And maybe we can, open up to the audience of like, hey, if you were in this situation, what did we do wrong? What did this diver do wrong? What could have we been done in order to avoid this nibble? So having seen that, I just kind of want to open it to the audience. What do you think we did wrong in this dive trip? How could we have avoided that?
I don't really know the answer, but I know that getting punched by with a face of a big shark just seems very scary.
Yeah. So biggest things, number one, obviously we're putting ourselves in a situation where sharks are being fed. So they are semi-primed, at least to explore. There's also this diver, if you saw, was wearing very contrasting colors. He did not have a hood on, and as if you saw, we can take a look at the videos later. Again, most divers did have a hood on in order to minimize contrast. He also have a bright orange, international orange surface marker. Even though it was rolled up, it was right next to where you saw the shark actually go in. He was not facing the shark. That's the other thing that they'll tell you whenever you're doing a shark bite, a shark dive. If a shark is coming at you, you want to make sure that you face the shark. There's something about establishing eye contact that tends to deter a shark attack. And also, we are diving in poor visibility. This day, there was a storm moving in, and we had about 30 feet of visibility, where normally it's about 100 foot plus of visibility. All right. Oh no. Okay, so unfortunately, that's not supposed to be there. That was supposed to come back a little bit later. There's one of my photos in the back of Barracuda because that's what we're going to talk about next. All right, so let's talk about barracudas. There are 22 species of barracudas. The only one that's really a threat to humans, or the only one that has at least been implicated in human attacks, is the great barracuda. Barracudas as a whole, they range in the Atlantic from Brazil all the way up to Florida. They've also found in the Indo-Pacific, the Red Sea, and the Hawaiian Islands. The great barracuda lives up to its names. It can be upwards of 8 feet, and its record, fishing caught is 102 pounds. They have, again, most people hopefully would know what a barracuda looks like. They are, and not just a great barracuda, but most barracudas have a very disconcerting behavior where they open and close their mouth. However, same as eels, this is normal respiration, so it should not freak you out. They do have a very elongated and narrow mouth filled with parallel rows of large knife-like cutting teeth, and they're known for a very voracious attack that often tends to sever their prey. Barracudas seldomly attack divers. When they do, usually there's murky water involved, very similar to shark attacks. Injuries tend to be more common in boaters dangling their feet or in fishermen removing the hooks. Splashing at the surface and underwater tends to mimic injured fish, and same as sharks, it can actually be an attractant. Bites from barracuda, as opposed to sharks, they tend to be straight or V-shaped, and because they're markedly smaller, they tend to have a lot less tissue damage. So I wanted to play this video for you guys to again exemplify what could happen around barracuda if you can make a lot of surface commotion. So there he goes, jumping off the boat, big splash, a lot of bubbles trailing. And there goes the barracuda. Don't know what happened afterwards. There was a lot of freak out and screaming in the video, but it's unclear from what happens after the video whether any injuries occurred. Sorry, it doesn't seem to be wanting to go forward. All right, these are chevron barracuda. These are not gray barracuda. These tend to be schooling, and this was taken in Fiji. So prevention of barracuda attack. Barracudas, again, are attracted to underwater commotions and surface splashing, so you want a very slow, deliberate movements, very similar to sharks. They're attracted to shiny objects, which could mimic prey. So again, make sure that you're not wearing any jewelry or anything that could sparkle underwater. Same as shark, you want to avoid areas of active fishing or spear fishing. And if you are spear fishing, try and keep your caught fish away from you. It's better to lose your lunch than your leg. We're going to treat the same as we treat the shark, but because there is markedly less tissue destruction during an attack, you are way more likely to achieve hemostasis without the tourniquet as opposed to a shark bite. All right, let's talk about next about moray eels. So there's approximately 200 species of moray eels, with only a few of them being large enough to cause serious injury to humans. Moray eels have a tropical to temperate distribution. They range in size from pretty small, 4.5 inches, and that's the Snyder's moray, all the way to the giant moray, and that's the guy that's pictured here, and they can be upwards of 10 feet and about 75 pounds. This picture was in Fiji, if I remember correctly. In the US, the most frequently large species encountered are going to be the California, the green, and the spotted moray. Morays, again, they have a snake-like body. You can differentiate them from other fish with similar profiles or from snakes themselves, as they have a lack of pectoral fins and scales, and they have very small, round gill openings. They live in crevices and holes in the reef. They also have pretty poor vision, and they tend to use their sense of smell to locate their prey. There we go. This is a snowflake eel, and if I remember correctly, this picture was taken in Indonesia. So moray eels, they tend to evade confrontation unless they're cornered or provoked. Bites usually tend to occur when a diver is reaching into a hole or a cave. Morays can have a pretty forceful and vicious bite, and some morays, unfortunately, have the tendency to bite and not let go. Some morays have pretty sharp, long fang-like teeth, and the majority of them are retrose, meaning they're facing backwards, so food tends to only go one way. Because of it, punctures, because of their bites, tend to be frequent, and lacerations can happen as the diver reflexively jerks his hand away or if the moray is ripped off. This picture was again in Indonesia. This was in the Banda Sea, and that is a honeycomb moray that the diver's looking at. So prevention, biggest thing is do not place your hand or any body part into any unexplored hole or crevices. Divers looking for lobsters need to be aware that they share a habitat with moray eels. And biggest thing that unfortunately you may have seen pictures out there, do not handle moray eels. That is just a recipe for being bit. Treatment. There we go. So treatment, hemorrhage analogous to shark and barracuda bites. Unfortunately, morays that remain attached need to be sacrificed with their jaws usually broken in order to be let go. High risk of infection with these guys secondary to huge counts of symbiotic flora in the moray's mouth. So the wounds need to be copiously irrigated, inspected, and imaged for retained teeth. You want to make sure you loosely approximate any laceration, unless again, it's going to be highly contaminated. You want to make sure you have prophylactic antibiotic and tetanus vaccination. So going back to, again, sharks, barracudas, and morays, you kind of want to follow your March algorithm. Make sure make sure that you treat the hemorrhage, protect the airway, augment respiration, augment circulation as best you can, and keep the patient nice and warm, as again, a cold person is going to get coagulopathic. All right. So next, I wanted to talk about octopus. These guys also do bite. They tend to be, for the most part, harmless and retiring, but occasionally can actually be quite playful with divers. They have a worldwide distribution, and they range from the shallow intertidal zone all the way to the deep ocean. They're usually found along rocky bottoms, and they tend to range from gigantic. The Pacific giant octopus has a tentacle to tentacle wingspan. I guess that's what you would call it, of 20 feet, and they can weigh 110 pounds. But also you can have these starsucker and pygmy octopus, which again, tentacle to tentacles, only 1 inch and only weighs 1 gram. New studies actually suggest that all octopus are venomous, but only a few of them can actually be deadly, and these tend to range in the 4 to 8 inch, again, tentacle to tentacle wingspan. This picture was taken, this is a larval long arm octopus, and it was taken during a black water dive in Lembeh, Indonesia. All right. So large octopus are rather powerful. There are reports of them drowning breath hold fishermen. Bites from their beak-like mouth parts can sever fingers and can cause crush injuries to extremities. There are rare reports of envenomations with pretty immediate bradycardia and hypotension. This was a mimic octopus, and again, I think this was also in Lembeh, Indonesia. This is not a very large octopus; it's only a few feet in diameter. But I've never dove with Pacific giant octopus. Now, most fatalities tend to happen because of these guys. So these are blue ring octopus. There's at least 4 species, but there could be up to 10. And the mototi is also very similar, but rather than having 50 to 60 blue rings, it tends to have 2 very similar to cheeks on either side of its eyes. These guys range from the Indo-Pacific, Australia, and the Andaman Islands, which are in the Indian Ocean. They tend to be very well camouflaged, but they can turn yellow, cream, or green, and then they show the bright blue rings usually as a threat display. So if you're seeing them very colorful and very bright blue rings, you're doing something very, very bad. The venom of blue ring octopus and mototis is a tetrodotoxin, which blocks peripheral nerve conduction. It's basically a paralytic agent which rapidly shuts down neuromuscular pathways. They don't have any cardiotoxicity that is known, so usually most people that code are going to be because of hypoxia, not necessarily, again, any cardiotoxicity. These have a lot of venom in them. It is estimated that each one has enough venom to kill 10 humans. So this guy is I can't forget whether this is a larval wonderpus or a larval mimic octopus, but it was again seen on a blackwater dye in Lembeh. So prevention, how do you prevent, again, becoming a statistics? Number one, don't handle any octopus, particularly small octopus. There are no known bites of blue wing octopus from divers observing the octopus. All bites seem to be related to people giving a ride to the blue wing, literally catching it and trying to transport it from one area of the reef to the other. So victims of envenomation usually collapse secondary to weakness, but they tend to remain awake. As I said before, if there is a cardiac arrest, it tends to be secondary to hypoxia. Scene first aid should include a pressure mobilization technique or a pit of the extremity, starting at the distal extremity, wrapping it relatively tightly to try and compress lymphatic spread, and then immobilizing the entire extremity. Symptoms-based treatment is just prompt respiratory support, but that could go all the way up to mechanical ventilation. Duration of intense envenomation tends to be short, about 4 to 10 hours, with complete recovery in 2 to 4 days. Residual symptoms are relatively uncommon. Unfortunately, there's no antivenom or supportive care. And supportive care for the wound is a usual wound care, though some people have recommended excision of the bite with primary closure. All right, so last in our biters, we're going to talk about sea snakes and sea kraits. 52 species in total of sea snakes and kraits, all universally venomous. There's not one that I would dare handle. Most commonly implicated in human venomations are the Stokes, beaked, ornate, the annulated, which is the one picture here. This was taken in the Snake Islands in Banda Sea and in Indonesia. The spine-bellied and the yellow-bellied sea snakes and the viperine sea snakes, those tend to be the most common ones that cause venomations in humans. They're distributed through the Indian and Pacific Oceans in tropical and warm temperate waters. Highest number of envenomations tends to be in the Persian Gulf, the Malay Archipelago, and just Southeast Asia in general. In the US, we can only find them in Hawaii. The only one that we have in the US is the yellow-bellied sea snake. This is the only pelagic sea snake, and thus is the one most widely distributed. For the most part, they tend to stay in coastal waters and coral reefs. These guys can dive incredibly deep, 100 meters, so 330 feet, and can submerge for about 2 hours. So it's not just on the surface and shallow that you could run into them, but you can run into them relatively deep. You can tell them different from fishes or moray eels by the presence of snakes. If you want to get close enough, you can actually see that they have valve-like nostrils in order to keep the water out. Most of them tend to have a really small venom and fang apparatus. It's too small to even, for the most part, penetrate neoprene. So about 80% of bites do not tend to result in significant envenomation. But unfortunately, these are incredibly venomous. The lethal dose of a venom from a sea snake is 0.05 milligrams per kilogram. Just to compare the elapids, so your coral snakes, your cobras are 0.69, so about 10 times more potent than your lapids and about 20 times more potent than your vipers. The onset of symptoms after an envenomation tends to be from minutes to hours. With the faster you develop a symptom, the more severe the envenomation. The bite, for the most part, because they have very small fangs, tend to be painless, with relatively vague first general symptoms such as euphoria, malaise, and anxiety. This then tends to progress to muscle weakness, as what they carry is the neurotoxin. Sorry, slides for the somehow are going very slowly from one to the other. All right, how to prevent? Don't handle any sea snakes or crate, whether they're dead or alive. Very similar to other snakes. And even a severed head can have a reflexive bite. Again, this was in the same place. This was in the Snake Islands in Banda, Indonesia, or in the Banda Sea in Indonesia, and that's a beaked sea snake also. This is along the same trip. I think this was also in Banda, Indonesia, or in the Banda Sea in Indonesia, and this is a banded sea crate. So how do you treat? Number one, you want to be able to ID the snake as long as it does not increase the number of victims, very similar as you would do with an envenomation inland. The affected limb should be immobilized with the pressure immobilization technique that we spoke about with octopus bites. And again, you want to be able to identify them, as antivenom is thankfully available for sea snakes. So talking or summarizing at least for your sea snakes and the octopus, because it's not just a bite, but there's actually an envenomation, immobilization of the extremity that is bit with supportive care for octopus, and actually antivenom for sea snakes is the treatment. So next we're going to move on to things that sting. All right. So these are your cnidarians. These are your jellyfish, your hydrates, your anemones. So this picture was in the Great Barrier Reef in Australia. So we're just going to talk a little bit about the nematocysts. These are the stinging apparatus of, which is the cardinal feature of all cnidarians. Then talk about the cnidarian syndrome, which is just basically your stings, and a very special syndrome, which is called the Irritate syndrome. So as I said, the cardinal features of all cnidarians is the nematocyst. This is what's pictured here at the top. This is their stinging apparatus. It is contained within a specialized cell called the nematocytes. You're going to have a trigger. That thing is called the cnidocyl. Inside of it, you're going to have a coiled or folded tubule. Usually that tubule is lined by barbs to help it penetrate and anchor into the skin. And throughout all these invaginations, you're going to have venom. The size of these guys are about from 200 to 850 micrometers, and they can deploy pretty fast at 2 meters per second. You're going to have upwards of 2,000 stings per square millimeter of skin. And this is what somebody actually, the exocytosis, or the actual firing after its trigger. It is thought to be osmotic in nature, which is very important once we talk about treatment. So this is going to be a slow motion, but you can actually see the firing of the metacyst and then there's the injection of venom. All right, so for clinical purposes, the features of envenomation are fairly constant with only a spectrum of severity. The severity is related to the season and the species. Some species become more potent depending on the season. Venom inoculation, meaning the size of the animal and the number of nematocysts are actually triggered, the size and the age of the victim, and their underlying health. Mild disease is usually characterized by immediate prickling or stinging sensation, which is accompanied by itching, paresthesias, burning, and throbbing, and this can radiate centrally. This is, sorry, looking at the picture, this was I forget the name of this jellyfish, but it was taken during a black water dive in Lamb Bay. But you can actually see the jacks of the fish inside the jellyfish. That tends to use the jellyfish for protection while they're in their larval stages. All right. So the engulfed site may become, going back to the jellyfish thing, the engulfed site may become red, brown, or purple, often in a linear fashion corresponding to what's called a tentacle print. And this is literally where the tentacle actually rubbed against your skin. You can have petechial hemorrhage, blistering, edema, angioedema, and wheal formation. Dyspnea from at least mild envenomation only happens if the face is involved and you have oropharyngeal swelling. Symptoms can last up to 10 days, but there can be local necrosis, ulcerations, so you need to be very vigilant for secondary infections. Hyperpigmentation can occur, and it tends to be there for 1 to 2 months, although it can be permanent. So this was this picture was taken in Raja Ampat, again in Indonesia. This is just a magnificent anemone, and you can actually see two pink clownfish inside of it. So the prime offenders for moderate to severe envenomations are the anemones and the Portuguese man of war. The Portuguese man of war is not just one organism, but actually is a collection of hydroids. Skin manifestations are similar or just more intense to compare to mild disease, but this is compounded by systemic syndromes. The Portuguese man of war and the anemone stings are usually extremely painful, but rarely are they lethal. Signs of severe envenomation include, again, agitation, nausea, vomiting, difficulty breathing. You can have irregular heart rate, hypotension, and paralysis, but again, death tends to be pretty rare. Interestingly enough, with more moderate and severe envenomations, you can get anaphylaxis from first exposure. So extreme envenomations, these are the ones that are terrifying. So extreme envenomations occur basically with a box jellyfish. Thankfully, there's only 72 known fatalities that have been verified. These are exclusive to Australia and Southeast Asian waters. Sudden death in a child was documented in the Gulf of Mexico from the Caribbean box jellyfish. Mortality rates with box jellyfish stings tend to be high, 15 to 20% untreated. The stings tend to cause pretty immediate and excruciating pain, with the victim usually collapsing from pain in 1 to 2 minutes. This is what it looks like. It's a rapid toxic skin reaction with formation of wheals, vesicles, and dark and red papules, which is your tentacle whip. You're going to have blistering and necrosis, which can develop in 12 to 18 hours. And the picture basically shows again the progression. The last picture is basically removing the eschar from a bad envenomation. So how do we avoid this? So prevention is going to be the key. Avoid areas in season with known jellyfish blooms. Pay attention to posted warning signs, particularly in Australia, where the Chironex, the box jellyfish, is known. In seasons where they are plentiful, that you will have warning signs. You want to make sure you give a wide berth to any seen jellyfish. The Portuguese man-o-war tentacles average about 30 feet, but they've been known to extend downwards of 165 feet. In Australia, not only are you going to have warning signs, but you're also going to have netted beaches in order to keep Chironex out. Also in Australia, they have this, again, mostly against the Chironex. This is a lycra protective clothing. With anything else in the water, you might want to make sure that you look but don't touch. Hydroids can grow in submerged rocks, lines, ropes, and foul boat bottoms. So how do we treat it? I'm actually looking at the picture. This was inland bay in Indonesia. This is a clownfish. The most interesting thing about this form is if you look at its mouth, you can actually see a parasitic isopod. You can see its two eye dots. It actually has eaten away at the tongue of the clownfish and basically now takes part in its meal. It does not kill the clownfish, but it does look rather interesting. So treatment, how do we treat Cnidarian syndrome? Decontamination of the tentacles by either glove hand, tweezers, or fingers as a last resort. You can also shave it off using either actually shaving cream or a paste of baking soda or talc, and you can use anything to shave it from an actual razor to a credit card to a shell. You want to decontaminate the venom with either papain vinegar or diluted ammonia, immerse it for 30 minutes and repeat until the pain subsides. If there is none of this, just try and wash it off with salt water, but you want to avoid fresh water as we spoke about with the firing or of the tubule. Again, it's osmotic. If you add fresh water to it, the only thing that you're going to get is more firing of the nematocyst. Depending on the species and where you are, there are some local remedies. So if you are traveling to an area where jellyfish can be affected, see what works best, what the local customs are. Again, some of them, they do vinegar, they respond better to vinegar, some of them to ammonia, some of them to papain. So you want to denature the toxin. So you want to immerse the extremity, if it is an extremity, in hot tub warm water, and you want to make sure that you immerse both extremities to avoid a thermal burn. Thankfully, there is an antivenom to Chironex to the Australian box jellyfish. It's been proven to be life-saving, decrease pain, and decrease the scarring. For other jellyfish stings, you want to make sure you use topical anesthetics, whether that's lidocaine or just plain ice. Topical antihistamines, steroids may actually help soothe. Prophylactic antibiotics is not recommended in normal wound care for ulcerated lesions. Again, this is an open wound exposed to disease, so you're gonna make sure the tetanus vaccination is up to date. The most important thing is, again, do not pee on jellyfish or anemone stings. But maybe this is what we should have been giving out, is like Dr. Gonzalez, #1 jellyfish sting. It's just all pure concentrated urine. And again, this is just sarcasm. This doesn't actually exist. So let's talk about irukandji. So irukandji is actually caused by another box jellyfish. This is native or only found in the northern waters of Australia. Unfortunately, it's very small in size. It's very hard to see. It's about 1 to 2.5 centimeters at the bell and 5 to 7 centimeters in length, although the tentacles can extend markedly further. Unfortunately, these guys are small enough that they can actually go through netted beaches. Very similar to the Chironex, you're going to get an immediate skin reaction characterized by stinging, pain followed by regularly spaced papule. The thing about this is that you get a massive catecholamine release with tachycardia, ventricular tachyarrhythmias, hypertension, abdominal and chest pain. Cardiomyopathy can happen with pulmonary edema and dyspnea. You can have cerebral edema and hemorrhage. You can get pallor and peripheral cyanosis from peripheral vasoconstriction. You can have oliguria and acute kidney injury. This is a very similar mechanism as a pheochromocytoma, and you're going to treat it similarly with phentolamine for hypertension control, fentanyl for pain. There are reports of magnesium sulfate that helps control the pain and the restlessness. So this kind of brings us to the end of our stingers. So with stingers, the biggest thing is what we tend to call the 3Ds. You want to decontaminate, so remove any tentacles which are present. You want to deactivate. So this is your vinegar, your papain, your diluted ammonia, not pee, not fresh water. And then you want to denature, and this is your immersion in warm water. And again, remember, whenever you're immersing an extremity in warm water, make sure you immerse the contralateral extremity to make sure that there's no thermal burns, as you can have altered sensation in that extremity. All right, let's move on to our next mechanism of injury, and these are the creatures that puncture. This is the picture. This is going to be a southern stingrays, and this is actually the shallow waters of Cozumel. All right. So first, we're going to talk about urchins. There are a lot of urchins. There's over 600 species of urchins, but thankfully only about 80 species or so have been implicating in human envenomations. They are again characterized by spines. These are cylindrical projections, and this can be either solid, which are non-venomous, or hollow, and then these are the venomous ones. Spines can be up to 1 foot long, and they are brittle, and they can easily break off inside a victim. Actually, looking at the picture, this is a fire urchin, which is one of the most venomous species of urchins. But these are commensal Coleman shrimp that actually tend to live on top of the fire urchin. So some urchins have what's called pedicelaria. Now, these are pedicelaria. The picture on the right is a flower urchin. And these things that look like little flowers are the pedicelaria. These things can actually grab onto a victim and then continue to envenomate. Now, most victims of envenomation, or the envenomation tends to happen as we stab, handle, or brush against a sea urchin. The pain inflicted by the spines, particularly these highly venomous ones, such as the flower urchin or the fire urchin, tends to be immediate and excruciating. With severe envenomations, you can have local muscle aching with visible erythema and swelling, but this can actually progress to actually involve paralysis. And you can also have hypotension, respiratory distress. Death, thankfully, is rare. Some urchins actually carry a little dye inside their spines, and while again the spines can break off inside of it, sometimes you don't have a retained spine, but what you have is what's called an urchin tattoo. And these guys, if assuming that you again don't have any spine, these will go away in 48 hours. You do want to be careful, particularly if you have something like this where you have punctures around a joint. If one of the spines were to puncture a joint, you can have a pretty severe and very quick synovitis. And if the spines are not removed, this can actually progress to arthritis. So prevention. Looking at the picture, this is again a fire urchin rather than the commensal Coleman shrimps that we saw. This is a commensal zebra crab that also lives on top of the urchin. So prevention, you want to use a wetsuit, you want to use puncture-proof shoes, look where you're grabbing, and for divers, good buoyancy is going to be the key. Treatment, decontamination, again, if pedicelaria are involved, you want to make sure that you scrape them off the skin as they can continue to envenomate the patient. You want to be able to remove the spines, or ideally try to remove the spine, but you want to avoid breaking them and avoid crushing any fragments left in the skin. Remember that you can have the tattoo, and that does not necessarily mean that you have any retained spines, and it should go away within 48 hours. If there's a question of retained spines, you do want to make sure that you image the patient, whether that is X-ray, ultrasound, CT, or MRI, and they should all show you if there is any retained fragments in there. If a joint is involved, surgical consultation is necessary. Very similar to what we have previously spoken about with the cnidarians, with the anemones and the jellyfish. You want to deactivate the venom by immersing in hot tub warm water for 30 to 90 minutes and repeat as necessary. All right. So starfish, the only starfish that can harm us as humans is the crown of thorns, and that's the one that's pictured there. Unfortunately, not only can these guys hurt humans, but these are responsible for vast destruction in the Great Barrier Reef. These guys have spines that are very tough and can penetrate neoprene, leather, and even the soles of sneakers. The spines secrete a mucus that tends to contain multiple toxins. Symptoms are immediate as soon as these guys penetrate the skin and they carry the venom into the wound. There's usually copious bleeding with mild edema. With significant envenomations, you can have constitutional symptoms with nausea, vomiting. There could be weakness, hypertension, and rarely paralysis can occur. Treatment, we're going to do very similar to urchin spines, hot water immersions, 30 to 90 minutes, which can offer significant relief of pain. Unfortunately, the pain can persist and local infiltration of anesthesia is sometimes necessary. Wounds need to be very thoroughly irrigated and explored to make sure that there's no foreign material. Very rarely do these spines get returned just because of how strong and how tough they are. Oh, all right. That video is supposed to be playing in the background, not in front of it. So next I wanted to talk to you about the cone snails. Unfortunately, we just have the video and I don't have the background. Apologies for that. So there's 500 species of cone snails, but only 18 have been implicated in significant human envenomation. With occasional fatalities, there's only been about 16 to 30 that have been recorded worldwide. Most harmful coal snails thankfully live in the Pacific and the Indian Ocean. While they do exist in the Atlantic and Caribbean seas, they tend to be markedly less toxic than their Pacific and Indian Ocean counterparts. Envenomations happen by a rapid-acting venom that comes from a detachable tooth that carries the venom, and this is basically shot out of the proboscis. I'll show you guys the video in a second. This is the proboscis right here. It's basically the mouth of the cone snail, and it tends to shoot out this tooth with a high venom. And this venom tends to be incredibly quiet acting. You can imagine a snail eating a fish. They want to paralyze that fish as quickly as possible. Mild envenomations tend to resemble a bee or a wasp sting, and usually associated with just a burning and tingling sensation. But again, severe envenomations include paresthesias at the wound site, which rapidly progress to limb paralysis and then generalized paralysis. Let me play you the video so you can see how fast acting, again, these poisons are. So again, this is the proboscis at the bottom with the dart coming out. You have rapid envenomation with paralysis of the victim. Again, because humans tend to be a lot bigger than fish, we don't get paralyzed that quickly, but unfortunately, diaphragmatic dysfunction and respiratory failure can occur after a cone snail sting. There we go, and there's your cone snails. So prevention is basically avoidance. Do not handle any live shells, particularly cone snails if you're unaware of the species. Do not carry them inside your wetsuit, clothing pockets, or BCD pockets as a what you thought might be an empty shell can harbor a live animal. Unfortunately, there is no antivenom. Yeah, there's no antivenom. Pressure mobilization technique, very similar to what we spoke about with your sea crates and your blue wing octopus, should be applied. And then cardiovascular and respiratory support is that priority in severe envenomations. Endrophonium, similar to what we use for treatment or at least diagnosis of myasthenia gravis, has been thought about possible empiric therapy for the paralysis. Okay. All right, so next, talk about stingrays. 200 plus species of stingrays, 22 live in the US water, 14 in the Atlantic, 8 in the Pacific. These guys cause about 2,000 injuries in the US per year. Thankfully, most of those are just simple injuries and not deaths. Round stingrays tend to cause the majority of the injuries in the Pacific, and the southern stingrays, which is the one picture here. Again, this was taken in the waters off Cozumel, is the one that tends to cause the most injuries in the Atlantic Ocean. There are freshwater species. None of them are native to North America. You can find them in Africa, Southeast Asia, and the Amazon. All stings, basically, again, from stingrays are purely defensive. They tend to happen as somebody basically approaches or usually more likely steps on the stingray. Now, stingray spine can penetrate wetsuits, leather, rubber boots, and even the wooden side of boats. Stingray spine punctures can cause both traumatic injury and envenomation. Lacerations and puncture are common and so are secondary infection because of, again, how deep they can puncture. They can go into bone, causing osteomyelitis. Lacerations and puncture basically, or the site of the laceration and puncture dictates the level of injury. Commonly, again, in the lower extremities, the foot and the ankle, as people step on the stingray. Unfortunately, fatalities do have occurred after abdominal and chest perforation, chest penetration. I think most people do remember Steve Irwin. He was killed by a short-tailed stingray. Oh, sorry. I'm not sure what happened there. It looks like I'm missing some part of my slide, but this was actually, this is a manta train at a cleaning station. And these 5 mantas, you can actually compare them to these are divers in the back, and you can see how massive these guys are. And these are actually reef mantas, who tend to be the smaller of the 2 species. Oceanic mantas are 2 to 3 times as big. But thankfully, these guys do not carry stingers. Wanted to talk about envenomations, and unfortunately this does not pop up the rest of my slide, but envenomation can cause local and intense pain and edema, variable levels of bleeding. The pain can radiate centrally, and usually there's a dusky or cyanotic appearance to the wound, which rapidly progresses to erythema and hemorrhage with possible hemorrhagic vesicles, very similar to a thermal injury. Late healing can happen, particularly if the wound is not thoroughly irrigated and there's foreign objects that are left in place. Systemic symptoms can happen also with severe envenomations. Stingrays also have a very, very powerful suction and crushing bite, and they have been known to cause hickeys or even sever fingers. All right, so we look at the picture. The picture's again another southern stingray. This is in the waters off Cozumel. That's actually my dive buddy Chris, who may or may not be listening to this lecture. Oh. All right, so prevention. You want to do this thing called the stingray shuffle, where basically the soles of your feet do not leave the sand. You want to step, basically shuffle your feet. What this is thought to create is enough disturbance to frighten away the stingray and basically avoid you stepping on them. So for treatment, as soon as possible, you want to immerse again in non-scalding water. You want to make sure you immerse both extremities. You don't want to cause a thermal burn. If hot water is not available, you want to irrigate with non-heated water or saline, ideally sterile. But if that's not available, tap water will do. What you're trying to do is you're trying to remove as much venom and mucus as possible. You want to make sure that, again, just tap water at the most. You don't want to immerse it in anything else. So as soon as feasible, you want to decontaminate the wound by removing the stinger or any other foreign body that could be embedded in there. If the stinger is lodged in the actual body, treat it as a weapon of impalement and secure it in place. Again, that is unfortunately how Steve Irwin died. The thought is that he got penetrated through the heart. He removed the stinger and unfortunately exsanguinated. Do not remove even in the appendicular skeleton if it is close to a wound. It is, sorry, close to an artery. Better to get to the hospital and treat it as a weapon of impalement. You want to make sure that you image the extremity or wherever the person was impaled. So you want to make sure that you remove all stingers and barbs, or any wound that is not thoroughly clean can fester for weeks or months. Prophylactic antibiotics are usually recommended, but thankfully, bad infections such as necrotizing fasciitis are uncommon, but osteomyelitis, if bone is involved, is relatively common. For any wound that is, again, deep, the patient needs to be monitored for 3 to 4 hours to make sure that systemic symptoms do not develop. Oh, again, unfortunately, that video is not supposed to be there. It's supposed to be in the background to play a little bit later, but we'll do our best and work through it. So wanted to talk about the scorpion fishes and similar venomous fishes, and these guys are distributed globally, commonly topical, but less commonly not topical, tropical, and less commonly temperate. These include the zebra fishes. Usually these include the lionfish, the scorpionfish, sculpin, and stonefish. That is supposed to be a lionfish picture in the background. This was taken in Indonesia also. They all have spines with venom glands. Other fish with similar characteristics, but not included in the zebrafish, include the toadfish, which we can find in Cozumel. Sorry, this is a scorpion fish, actually, and you can see it is incredibly well camouflaged. And a toadfish, a splendid toadfish, right down there in the crevice. The venom of these guys is usually injected by direct puncture into the skin, and all envenomations are defensive from either stepping or laying on the animal, or now recently in the Caribbean and Atlantic from actually handling of lionfish as a means of source control for an invasive species. And so this is how basically the envenomation happens. This is actually a stonefish that the neoprene is actually being brought over the spines, and you can see how much venom actually comes out. So again, these spines can penetrate wetsuits, so you want to be extremely careful. So envenomations can vary from mild from the lionfish to moderate from the scorpion fishes to severe from the stonefish. Immediate and intense pain that tends to radiate centrally, peaking 60 to 90 minutes after envenomation and lasting 6 to 12 hours. This tends to be for the lionfish and the scorpionfish. Unfortunately, stonefish, the pain can be severe and last for days. This pain has been described as so severe that can actually cause hallucinations and delirium. Systemic effects are also common, including neurological symptoms, and death has been reported. Nope. So this is a stonefish puncture wound, and you can actually see it in the extremity with blistering of the hand. All right. Last, we're going to talk about billfish and needlefish. So needlefish, I don't have a picture of them here. There are long, very skinny fish with very protrude not nostril, but a rostrum. These are thankfully relatively small. They tend to be 2 to 3 feet and only 1 to 2 inches in girth. However, they can exit the water at about 40 miles an hour and have flown into people, spearing them in the chest. Abdomen, extremities, head and neck, and exsanguinations have been reported. The biggest one that you want to be careful for is the sailfish. A sailfish in water can reach 70 miles an hour. Usually when you're diving with sailfish, it's involving a bait ball, and the bait ball tends to go to you for protection. So as the billfish comes in, you unfortunately can be speared. Not only are they dangerous in water, but they can be extremely dangerous out of the water to fishermen. As you can imagine, the fishermen love them because they're very acrobatic. They do jump, but they can jump in the boat, causing severe injury. And these guys are massive. The record of a billfish is it's almost over 14 feet long and 1,500 pounds. So you can imagine the force of impalement if this thing were to actually hit you. There you go. There are reports of actually divers being speared. This is Steve Kovacs. These pictures came out of the Divers Alert Network Alert Diver magazine. Steve is actually a very accomplished underwater photographer with specializing in black water photographer, but he ended up getting speared by a spearfish, which is basically a billfish with a very, very short rostrum. The bill hardly extends below their lower jaw. And last year, during a black water dive, he ended up getting speared by one. Thankfully, he ended up doing okay. Treatment, you're going to treat them the same as what we talked for sharks, for barracudas, for morays. You want to make sure you follow your March algorithm. This is a weapon of impalement. Usually, these guys are so big that they have pulled themselves out, but except for the needlefish, which are small enough that may actually remain in place. All right. Last thing that we're going to talk about is things that irritate the skin. Um, Picture. Unfortunately, there's not a whole lot of pretty pictures of most things that cause dermatitis, so I just gonna put pictures of people swimming in the water. This is a whale shark in La Paz in Mexico, and that's my lovely wife in the back of the whale shark. So first, let's talk about sponge dermatitis. Sorry, going back to dermatitis, one of the things that is very important, even though it is maybe one of the less exciting things to talk about, dermatitis affect 25% of the individuals going into the water. So this is actually the most likely thing that you're going to encounter from as a consequence of somebody entering the water. So sponge dermatitis, this is a syndrome that occurs primarily in divers and people who collect sponges for a living. It's especially described in Australia and New Zealand. There's a brief initial asymptomatic period after touching the sponge, and it's followed by a stinging and itching that often increases in intensity over days and can get to the point of very severe. Cessation is accompanied by erythema at the site of contact, which later could develop into papules, vesicles, and bulla. Picture, this is actually from Cozumel, who has beautiful sponge formations for anybody who's ever dove in them. This is the culprit. Sponges have spicules inside of them, and that's what gives them the shape. These guys can be embedded in the skin and can cause a type 4 hypersensitivity reaction. Again, the picture, it's another sponge in Cozumel. Treatment, or I guess prevention, avoid contact with the sponges. Thankfully, relatively simple. Treatment consists of irrigation of the skin with copious saline or any seawater. You want to be able to, what you're trying to do is you're trying to remove the spicules. You can also use duct tape or contact cement in order to kind of peel them off. The pain can be treated with application of cold packs, oral NSAIDs. In severe cases, parenteral opioids are necessary. Topical steroids, usually hydrocortisone 1%, will quell the itch pretty well, but may not be helpful in severe cases. Sometimes oral steroids or systemic steroids are necessary. Most people tend to recover pretty well within weeks, and antihistamines, at least for these guys, are not known to be effective. Uh, Again, particularly with sponge dermatitis, you want to make sure that the patient has tetanus vaccinations, particularly in the setting of a severe dermatitis. All right. Next, let's talk about seaweed dermatitis. This is one of the most common things that you can actually find. They range from relatively mild to somewhat severe, which we'll see in the next few slides. This is as opposed to a allergic dermatitis that we saw with sponge. This is actually an irritant dermatitis, basically from contact with from toxins produced by the seaweed and with contact with the skin. Usually itching, burning, a red rash that can appear within minutes to hours after contact with usually filamentous algae that are beneath a wetsuit, or a wetsuit or bathing suit. Looking at the picture, this is this is an ornate pipefish, and this was taken in the north coast of Bali. So treatment, or I guess avoidance number one, you want to avoid algae after exposure. Uh-oh. I cannot see the screen. I'm assuming you guys can't see it either, so I'm going to try and restart it. Can everybody see it now, hopefully?
Looks good now.
There we go. So prevention, you want to avoid contact with algae. Most dive boats, if anybody's ever been on a dive boat or a snorkeling boat, you've seen that there's usually freshwater showers afterwards. They're not just to rinse out the salt water, but actually to be able to get rid of any contaminants that you have on you. So very important after a water immersion is going to be a freshwater shower with soap and water. So treatment, again, decontamination is going to be your friend. You want to vigorously scrub with soap and water. You want to rinse enough to kind of wash all the filaments out, since this is a contact, an irritant dermatitis, not necessarily an allergic issue, an allergic dermatitis. If you do develop a rash, usually subsequent immersions with isopropyl alcohol and then a hydrocortisone cream with oral antihistamines and a topical steroids tends to help the issue. Some of the more severe, if it goes. There we go. So more of the severe contact seaweed dermatitis tends to happen because of this one particular species called Limbia. This is a cyanobacterium and produces toxins which can result in serious reactions and skin necrosis. They can grow independent, similar to the picture, but can actually grow mixed with other algae. It is impossible or incredibly hard, I would say, to recognize. This has to be lab identified. So being out in the field or diving, you're not going to be able to identify what kind of species of algae it is. But you can see the intergluteal cleft of this poor person, how bad it got from epidermal and dermal necrosis. The picture, this is actually during a blackwater dive. That's actually a blade of seagrass with a very, very small octopus at the top and a jack actually using the seaweed for protection. You can see these filamentous algae that are growing on top of the seaweed, and it is impossible, or the seagrass is what it is. It is impossible to tell what kind of species that is, so avoidance is going to be the key. Prevention, again, you want to remove the offending organism by a thorough shower with soap and water. And you also want to make sure that your bathing suit or anything else that has been in the water has been thoroughly cleansed, excuse me. Again, similar to the sargassum dermatitis, you want to, if you do develop a rash, you want to immerse, have subsequent immersions in isopropyl alcohol, and topical steroids can help with the rash and the itching. All right. So swimmer's itch, this is our Karyll dermatitis. Our Karyll is one of the larvals of the schistosomes. And this tends to happen basically as you're going into the water and as our Karyll penetrates your skin. We are not the intended organism, we're not the intended organism. And as the dyes inside of us, it can cause a pretty severe allergic response. These tend to happen for the most part in fresh water, but it has been reported in brackish and salt water. Schistosomes are found throughout the world. Oh. And there's usually the life cycles. Avians are that tends to be the most common one encounter, with the Karyll penetrating again human skin and causing severe reactions. Treatment again is antihistamines and topical steroids. There's unfortunately not much that you could do to avoid it, except for maybe avoiding areas of water that are known for high concentrations of the schistosomes. But unfortunately, these guys do happen in all over the world. So unless you're choosing to never go in the water again, there's not much you can do to avoid them. The picture was, again, this is a sea turtle with diver, and this was taken out in the Banda Sea. If I remember actually correctly, this was actually in the Snake Isle, so in the same place that I took the pictures of the sea crates. All right, next we're talking about sea bathers eruptions. So sea bathers eruption is due to a skin penetration from larvae of the cnidarians, or again the jellyfish, which are found only in salt water. The tiny jellyfish larvae can release their nematocysts and inject toxin. The distributed lesions are basically in areas of exposure, again bathing suits, wetsuits, or points of pressure, such as like the wristband of your wetsuit, or flexural areas where they can collect. Skin lesions are inflammatory papules and often have vesicular pustular lesions. They're very frequent in the Atlantic of North America and in the Caribbean. It is less likely described in other waters. Children is what tends to have the most severe metamation. It's just unfortunately in nature of their size. There we go. So that is the picture. So the picture is a juvenile jack actually hiding inside a larval jellyfish, and this was taken during a black water dive in Lembeh, which is a small island off the coast of Indonesia. So prevention very similar to the algal dermatitis or the seaweed dermatitis. You want to make sure that you have a thorough rinse with soap and water. These guys, you actually do want to use soap and water as opposed to a known jellyfish or anemone stings where you do not want fresh water. Treatment, vinegar or papain rinse. You want to use calamine lotion to treat the itchiness, and topical or systemic steroids in order to, again, decrease the itchiness, the redness. The picture, this is called paper nautilus or an argonaut, and it's on top of jellyfish. It actually uses the jellyfish for protection, and it was shot in during a blackwater dive in Lembeh. So I've talked a lot about things that could go bad in the ocean, and I'll tell you that really with the thousands of dives that I've done, there's only one thing really that scares me, and it's this. And I'll give you a clue, it's not the shark. It is that guy. That is called a Titan triggerfish, and during the full moon, they become incredibly protective of their eggs, being known to, again, bite divers, and they don't care about sharks. They will bite a shark. And I think that's the end of my lecture. What questions could I answer?
Thank you so much, Dr. Gonzalez, for that incredible presentation. When Oceans Attacked definitely delivered, and I know I don't just speak for myself when I say that I'm pretty sure we're all walking away with a much deeper respect for the sea, and also have a few more tools in our wilderness medicine kit. And now we can all agree to not pee on our friends, right? Before we open the floor for questions and discussion, I'd like to do 2 more giveaways. Again, you must be present to win. So with that, let's go back to our magic name picker. I did type the names of the remaining participants in here so we don't have to go through all the 100 registrants and figure out who's still here or not. So let's give her a spin. Oh, Joaquin Jones, are you still here? You can't see the participant present list when I'm sharing my screen.
I'm still here.
Excellent. For you, tonight I have a standard 36-inch roll SAM splint that most people are familiar with, some stickers, a Narcan, a pocket CPR mask, and I also have some of our Dude RN nurse creations just to show you guys what he makes. I didn't agree to like show these off for him or anything, but how cool is it when someone just like thinks of something and makes it because they want to make things better? So if you work in the field, these are for like pocket syringe management, you know, you're like redosing from the same syringe. So you can just put them on like your vest or wherever and save your syringes. Or there's a multi-syringe holder for 3 syringes of different sizes. You can also use it for some ET tube stuff, I believe, if you want to freestyle a little. So email wildmedwednesday@gmail with your mailing address so we can get it to you. And for our final giveaway tonight, is David here? Doesn't sound like it. Let's spin again. Thea.
I'm here. Thank you so much.
Thea, for your grand prize, we have the full complement of 3 Dude RN creations. You saw the 2 syringe holders, and then he's also created a little ET tube holder. Not as relevant when you're in the hospital, but when you're in the field and things are bumpy, this hooks onto the tube so that you can change out the bags or whatever on top. And there's also a little light to help you if it's not a well-lit situation. Couple pocket masks, some stickers, a couple Narcans, and then I've actually never seen this before. It's a Sam Splint XL. It's as long as the traditional roll-up one that everyone's seen, but it's for like a legit lower limb. It's this much wider. So there you go. Email us at wildmedwednesday@gmail with your mailing address. So now we'd love to open things up for questions, not just about tonight's topic, but also definitely pick Dr. Gonzalez's brain about his underwater photography, his journey through FOM, his pursuit of the DiDMM, which is a little bit less common than the DIM, so he's a good resource to have on hand. And even if you just have personal stories that are relevant to talk about or relevant to what we talked about tonight, we'd love to hear those too. You can unmute yourselves or type them in the chat and we'll say your questions for you. Dr. Gonzalez, do you know which tourniquets work best underwater?
Never had to use one, thankfully. The most common carry tourniquet is usually the cat tourniquet, just probably because of their small size and ability to easily deploy. However, it depends on who you ask whether it's worth carrying one or not. I definitely always carry one with me, but that tends to stay in the boat, not necessarily in the water. But I wouldn't venture to say that I'm not aware of any head-to-head comparison between them. But I would venture to say that the majority of people are going to be carrying cat tourniquets if they're carrying one. And again, I tend to have them usually leave them on the boat in the first aid kit.
I've never had to use one in a super wet situation either, luckily, but I've heard, not in like a specific academic setting, with like concerns of Velcro working appropriately underwater. But Diana is mentioning something called a Slishman wrap that I've actually never heard of.
Yeah.
I guess I'll Google it, or if Diana wants to share what it looks like or some pearls.
It's a pressure wrap, and it functions as a tourniquet. We had commercial diver, and I was a part of the standby team. I used to work in the offshore industry, so we had a welder that sliced his leg in a very in a horrible way open. So we were able to put that tourniquet at depth, and I mean, as much as we can at depth, control bleeding. But the Sleshman wrap was actually pretty easy to put on, and um, it worked very well. It's pretty new, so I
Yeah.
guess not as known, but I like it because it serves the purpose of not just a tourniquet, but it can also be for bandaging, and it could also be for slinging or swathing. So it's like a multi-tool.
Yeah.
I just Googled a picture of it and I'll open a link and put it in the chat so you
Yeah.
guys see. But Dr. Gonzalez, I think this might have been what you were telling me about today. Like
This
this
this was
stretchy.
exactly the one I was telling you today. Yeah. Yeah, so
Yeah, just today.
we couldn't figure out that we couldn't figure out the name of it, but that is actually one. I carry two of those, but I tend to carry those in my backpack when I'm mountain biking because they are very simple. They're super compressible. They also have Velcro on them. So I'm not sure that the Velcro argument of it doesn't work underwater. I don't think that that's true. And I would say that that's not true just because a lot of our equipment diving has Velcro on it. What can happen is with repeated use, you can have sand embed in it. And then it's the sand that prevents its function, not necessarily the Velcro. So as long as your Velcro is relatively new, there should be no reason why it shouldn't work underwater. But yeah, these are fantastic. Again, I've never had to deploy one, but I do carry some in my bag when I'm mountain biking.
Thank you for chiming in, Diana. I appreciate your thoughts. Another question that we had was, is a ray sting lethal to the animal, kind of like a sting to a honeybee?
No, they will actually regrow their barbs, and depending on the stingray, they can have anywhere from one all the way up to four barbs that can actually impale you. But no, once they basically use it, they'll just regrow it. They are vulnerable while they're regrowing it, but no, they will actually regrow their stinger and live to fight another day.
Awesome. I thought that was a neat question.
Dr. Gonzalez, thank you for a really great talk on the stuff nightmares are made of. I wanted to ask, does your kit kind of vary based on when, how, where, and why you're accessing the water, or do you have some things that are just absolute standards that you always take with you whenever you're going in or near the ocean?
Yeah. So I'll tell you that I love collecting things, which is I think most people I think like most of us have a problem with collecting toys and things like that. And somehow I love to collect medical kits. So I end up having like three different medical kits. I have a very, very small one that I take in my backpack if I'm like backpacking, mountain biking, doing things like that. I have a larger one that I travel with, and this tends to take care of most emergencies that you're going to be able to carry in the water. And particularly, I think, Andrew, it just depends a lot of where you're going. I mean, if I'm going to Cozumel, where the chamber and the hospital is all of like 10 to 20-minute boat ride, it's a lot different than what I carried when we went to Indonesia in January. When we went to Indonesia, the closest evac zone, so the closest place where a chopper could pick you up was usually about a 4-hour drive or a 4-hour boat ride from where the dive sites, and then it ended up being another multiple hour chopper ride in order to get to the chamber. So I think a lot of it depends on where your definitive care is in a situation like that, where if something bad were to happen, it's going to be hours before I can get to help. I'm going to carry a lot more extensive kit than if I'm just in Cozumel, where it's like, well, we might throw on a tourniquet if something bad were to happen. In definitive care, it's going to be 20 minutes down the line. I'm not going to worry about taking the tourniquet down because, again, they're going to be able to do it in their ER. So the other thing that I do a lot, it's it's source stuff where you get to. There's no point in carrying a giant thing of vinegar with me. I tend to source all that stuff in country whenever I get there.
Great question. If you had to pick your two most essential things that you like in your med kit, what are they?
I mean, for diving, okay. I'll tell you that despite, again, I carry a kit in order to treat exsanguinations and things like that. The only things out of my kit that I've had to use, actually, do we have 2 minutes for me to go get them?
Totally. And if
All
anybody
right,
else
hold on.
is like an avid ocean goer or whatnot, your top or two. Everybody loves to know about the med kits.
Well, wait, sorry, my daughter's screaming at me because it's bedtime and somehow she's still awake.
I know truly the things I've honestly used out of my personal med kit, not when I'm like working an event or contract or something, are really just like Benadryl for friends and stuff. Luckily, never anything super exciting. Learn the value of basic meds.
It's always the
So
Band-Aids.
yeah, I currently cannot find it, but I'm gonna let me just Google it really quick, and I'll put it in the chat. So in diving, the most frequent thing that I have encountered is going to be ear problems from a perforation that we had actually prior to this trip that we took in January that we had to follow up. We had to follow up during the boat in order to clear the patient for diving through otitis externa. So what I carry is a very, very tiny otoscope, and it actually transmits directly to your cell phone. So it's very easy to actually not only see it, and you don't have to worry about carrying an entire otoscope with you, but you can actually take pictures and videos. And what we did is then I remotely uploaded those photos to our EMT colleagues here so that the patient was cleared for diving. Along those lines, usually antibiotic ear drops, and there's a do-it-yourself antiseptic for your ear. And it is a 50-50 mix of vinegar, 5% vinegar, and what's it called, and hydrogen peroxide. If I'm the medical advisor for the dive trip, I basically just try and ask everybody to do it right after diving. That tends to keep your ears clean and dry.
That is the
in order
star answer right there. That is so
yeah.
true.
And again, it's one of those where prevention is so much easier than actually curing. You can imagine, again, when we were in Indonesia, this was a trip that was 2 years in the making. Everybody wanted to dive, but once you get on otitis externa, that's going to be the last thing that you're going to want to do. And being able to diagnose people with the otitis externa and just being able to, again, this is hydrogen peroxide and vinegar is something that you can source in country. You don't have to worry about taking it really anywhere in the world that you are.
I have one of those otoscopes too that you just connect to your smartphone. I got it a couple of years ago, so I don't even remember what brand it is or anything, but I can vouch that they're pretty cool, and they make a good party trick also, so you can show people, you can find out who in the room at your Christmas gathering has the weirdest earwax and stuff.
That I got on Amazon, and it was only like $20.
So the one that I have, and I'm not trying to necessarily endorse Amazon, but I'll put it in the chat if I can figure out how to do that. Now there's the chat. So that's the one that I actually carry with me. It's super easy to charge, and I charge it usually once before I live on a trip, and I've never had to charge it again. And again, it connects to your phone, super easy to take pictures and send them. They do come with all these other attachments in order to remove wax and remove anything else that could have potentially crawled in your ear, but never had to use those either. So again, I think this is the one piece, or again, this is the one thing that I've had to use the most. It's not the one thing that I love to carry because I think we all love to carry like our trauma shears and we like to carry our, our cat tourniquets. But I've never thankfully had to use it. But this thing I've used plenty.
Do we have any other questions for Dr. Gonzalez?
I do have a question. Could you tell us about your DiDMM journey? I'm a DiDMM candidate myself. So
Yeah.
your experience.
Yeah, so mine was a little bit easier because some of the requirements I already had. Like I said, I became a dive master when I was in college, so I already had my my rescue diver. That's part of your that the things that you're going to require. You're also going to require attending the medicine at sea, sorry, the marine medicine conference that happens in San Diego. And last year, they actually managed to do the conference and the safety at sea, which are also requirement back to back. And I believe that they're going to try and start doing that. Safety at sea is what I found to be one of the hardest things to do. There's only like a few places, 3 or 4 places in the country that offer safety at sea, and it's a 2-day course if you take most of it online beforehand. And it's 2 days of basically some lecture and a lot of like when I was in San Diego, just jumping in San Diego Marina and trying to figure out like this is how you're going to conserve body heat and actually survive. And it was actually a fantastic course. I highly enjoyed that. I got my saline certification, which is part of again what you need. You can I think just get through with an ASA 101. That's through the American Sailing Association. That's the intro to keelboat sailing. But I actually went through and got all the way through 103, 104, which basically now certifies you to independently charter a boat and sail a boat on your own. So I have my international proficiency certificate is I think what it's called. So technically I can sail a boat anywhere in the world in theory. The other things that I think are alternatives, Met Sail, it's not required. There is an alternative to Met Sail. And the alternative to Met Sail is you go to the conference in 2 weeks, which if you're there, I'll see you there. I'm doing the DiDMM pre-conference, happens every other year during the summer conference for WMS. And the alternative to that is that then you do Met Sail. And you also have to do the dive conference. There's a couple of dive conferences that count for the DiDMM, but do not necessarily count for your FOM if you're doing both at the same time. I know this year's dive conference is going to be in La Paz. So I'll actually be there at the dive conference too. And but I did it when I did it in Cozumel through Mayo. And while it counts for your DiDMM, it does not count for your FOM. So if you're trying to double dip, you want to make sure that you know that it may or may not count, and you gotta talk to either Alicia for your DiDMM and Gabby for your FOM through Wilderness Medicine to see if they qualify.
So Dr. Gonzalez, they let you, you don't have to like declare yourself as doing the DiDMM and then like complete every single thing in it, like some academic programs are. Like you could be like, oh, I don't really know dive medicine. I guess the only example I can think of is like if I was doing the DIM, I could be like, I took an avalanche rescue course elsewhere. It sounds like it's kind of like the equivalent of that. They let you do something like that.
No. I think the only thing that that there is an alternative to is the medicine at sea. That one is not compulsory. The alternative to that is to do the pre-conference that happens every other year during the summer conference. Like I know because the summer conference 1 year they'll do DiDMM, the next year they'll do DIM. So this year's conference in Wisconsin and like Geneva, it's going to be the DiDMM pre-conference. Last year at Snowbird, it was the DIM. So those are the only ones that I'm aware of are interchangeable. You have to do a dive conference. You have to do the marine conference. You have to get a you have to get a rescue diver, and then you have to have some level of certification of water safety. Again, I did my sailing course. That I'm actually looking it up. That there's alternative. There's Swiftwater Rescue course, personal watercraft safety course, surf and sub aquatic rescue and water safety courses, lifeguarding course. Again, if you're a lifeguard, I think that counts. Paddleboard safety courses, and this is again outside of your safety at sea, which is also required. So again, everything is a bit required. I think the only one that are interchangeable is MedSail, which will happen in January. That happens in the British Virgin Islands, and you can exchange that to DiDMM. Sorry, to the summer pre-conference.
Awesome. Great info. Do we have any other questions tonight?
Yeah. And if people are interested in MedSail, I have not made up my mind, or at least I have not been given permission to go. But I do have some friends who are going. So if you're interested in going and sailing or sharing a sailboat, I can get you in touch with them.
That's valuable, because if you get like the certain number of people that can go on the boat to split it, definitely drops your costs. And I also
Yes.
going to the summer conference at the end of the month, Dr. Gonzalez, the winter.
I will be there.
Yeah, so reach out if you're going to be there too and you want to connect with Dr. Gonzalez in person.